Welcome, everyone. Welcome to our World KMC webinar, KMC Time Counts, Learning with Families, Frontline Workers, and Innovators. Welcome. Please introduce yourself in the chat. Next slide, please. Welcome once again to the Implementation Toolkit for Small Sick Newborn Care webinar. This toolkit aims to be a multi-country, multilingual learning for high-quality small sick newborn care. We had more than 62,000 unique visitors from 170 countries in 2025, and this continues to be a platform for newborn health workers globally to meet and share tools in 15 languages, technical content in French, and to be a linked community of practice in English and French. Just to note that this webinar is being translated to French live, and we have a French channel open for our French speakers. Next slide, please. Welcome once again to this webinar, KMC Time Counts, Learning with Families, Frontline Workers, and Innovators. This webinar is co-hosted with PANSAA, Partnership for Accelerating Neonatal Survival Across Africa. To join the Newborn Toolkit to hear about webinars, news, and share tools or ideas, please sign up to the Toolkit newsletter. And we have a QR code on the screen now for the newsletter in English, the newsletter in French, and you can connect with us on social media. Next slide, please. So a bit about PANSAA, which is a partnership between Nest 360, the African Neonatal Association, and includes the African Neonatal Network as well. And it aims to be the biggest neonatal network across the continent. On the screen now, you see where PANSAA is in terms of the African Neonatal Network, the African Neonatal Association, and Nest 360 facilities. You see on your screen now a QR code where you can learn more about PANSAA. So please do use your handy devices to check the website and learn more about how this network aims to connect neonatal networks across the continent. Next slide, please. Welcome once again to our KMC webinar. You will know that, or maybe you might not know, but if you don't, we've had past webinars on this topic, and the recordings are available for shared learnings. Great ones on KMC. Last year, we had a webinar on KMC with quality, duration, nutrition, and data that matter. And the year before that, we had what's next for Kangaroo Mother Care before clinical stabilization, focusing on the Uganda Omwana trial and economic evaluation results, which was published in the Lancet. And these webinar recordings are available on the Newborn Toolkit website for you all and for us all to continue learning and being KMC champions wherever we're stationed. Next slide, please. And also last year, we launched the KMC Action Pathway. We all believe in KMC, but how do we make it work well? So this pathway aimed to be a KMC with high quality information on how we can simplify implementation of high quality KMC through the project management cycle. So we encourage you all to share tools and resources for KMC that we can add to the pathway. And on the screen now, you see a QR code that can link you to the pathway on the Newborn Toolkit website. Next slide, please. And our upcoming webinars. So on the 16th of June, we have a webinar on leadership and governance, which will focus on neonatal networks, what works to move faster together. And then on the 21st of July, we'll focus on human resource, which is the neonatal workforce equation, how many, how much, how fast. So we have many exciting webinars in 2026. And thank you all for joining once more. My name is Mbozo Sipalo. I'm one of the co-leads of the Newborn Toolkit and a medical doctor from Zambia. Very excited to be here today, welcoming you all to this very exciting webinar. And I will hand over to Federica Casera, who is, next slide please, the Neonatal Health Program Manager for Paolo Chiesi, to give us a bit on our webinars, but with the French touch. Over to you, Federica.
Thank you, Mbozo. Et bonjour à tout le monde. Pour les participants francophones, voici une version française des titres des prochains webinaires que Mbuzo vient d'expliquer. Alors, le premier webinaire s'intitule « Réseau néonatal, quelle approche fonction pour avancer plus vite ensemble ?» qui s'y tiendra le 16 juin. Et le deuxième webinaire portera sur l'équation des effectifs en néonatologie, l'équation, désolé, des ressources humaines en néonatologie, combien, à quel coût et à quelle vitesse. Il sera prévu le 21 juillet, mais vous trouverez également toutes les informations et les liens en description sur le site web de la boîte à outils qui est www.newborntoolkit.org. Back to you, Mbuzo.
Merci, Federica. All right. So very excited to introduce our two amazing co-hosts from Southern Africa, Dr. Natasha Rhoda and Dr. Gay Mundundu. Congratulations, Dr. Gay, for officially being termed a neonatologist and for graduating recently. And this is a recent photo from her amazing milestone last year. Next slide, please. All right, so Dr. Natasha Rhoda. Dr. Natasha Rhoda is an ST60 neonatal clinical advisor. She is the PANSAA KMC workstream co-chair, so very timely and very great that she's able to co-host this webinar today. She's at University of Cape. She has affiliations at the University of Cape Town at the Children's Institute with a background of being a neonatologist for over 20 years. And yeah, very excited to have you here, Dr. Natasha. And next slide, please. We have Dr. Gay Mundundu, who's a neonatologist based at the University Teaching Hospital, PANSAA KMC Workstream Co-Chair, and the ZPA Neonatal Zambia Pediatrics Association Neonatal Subcommittee Chairperson. And yeah, very, very excited to have you both. And over to you, Dr. Gay and Dr. Natasha.
Good afternoon, good morning, good evening, wherever you are. Oh, I'm so delighted to be here today. We have got a global panelist, as you can see in our talks from 1 to 5 for our global audience. And I know the members are going to come ticking on because this was one of the best webinars that the Toolkit has had. And you can see the talks 1 to 5, and we actually want to start off quite intentionally with the forgotten parent. And that would be specifically the father. Fathers at the forefront of KMC, specifically for KMC support and care to the mothers. And in fact, in South Africa, we don't call it only KMC, we also call it KFC. That's not chicken, that's Kangaroo Father Care or Kangaroo Family Care. The second talk would be specifically the direction that this theme wants to take, which is about KMC duration, one of those unanswered, how long is long enough? We know we need to have enough time on that. Alex is going to take us, and in part 2 of his talk as a pioneer of IKMC in Zimbabwe, what works, what doesn't work. And then Helen, our researcher, is also looking at companions. And very, very importantly, Julius, without data, we don't have good research. And Julius will take us through data for action. What do we have and what do we need? So without further ado, next slide, please. I would like to introduce you. Next slide, please. Yeah, there we go. I would like to introduce you to Kateregga Bazilio. Not only is he a businessman with an acute bachelor degree in commerce, but more importantly for this webinar, he is the father of preterm infants, and he's going to tell us his story and his family story of being a preterm father based in Uganda. Thank you, Kateregga.
Yeah, thank you very much. My name is Kateregga Bazilio, and I'm a preterm dad. I'm a father to twins of their preterm babies. What happened to me was that my wife got pregnant with twins, hematoma. Then she got pregnant, and unfortunately, while she was pregnant, one baby got a problem with the head while she's inside. Unfortunately, one baby dies, and we had to spend with one dead baby inside, then the other one was still alive for 1 extra month until we waited for the other one to gain some weight. until the system would really handle the baby. So it was really a hard moment for us as parents of preterm. As we parents, it was really very hard because, I mean, sleeping with your wife knowing that one baby is dead, then the other one is alive. It was really a hard one. So maybe let's first have the video, then we can proceed.
Hello, we are the Preterm Infant Project of Uganda, a network that supports preterm parents out there in the communities by teaching them kangaroo, moving with them the journey of prematurity till our babies have progressed successfully, and we are 2.5 and above. Today we are going to talk about the role of fathers in the KMC. Some of our fathers have the fear that these babies are too small and too fragile, so they can't afford to put the baby skin to skin because they have the fear that the baby may fall off. Secondly, our fathers, some of them believe and think KMC is only and only supposed to be done by a woman, and most especially the mother. Thirdly, some of our fathers are so busy with work. They come back from their workplaces and they're so tired and they have fatigue. And one of the things that we always emphasize is the person practicing KMC has to be okay. I mean, like, you're not tired that you doze off and throw the baby. Then the other thing is, some of the fathers think certain roles are only and only supposed to be played by the mothers. Hence, those are some of the challenges that we have as to why some of our fathers do not practice in KMC. Start with those that practice KMC. The baby seems so attached to the father because initially, as we know, is KMC helps the baby bond with the father. And in families whereby a father is not practicing KMC, the baby doesn't bond so much with the father. A family whereby a father is practicing KMC, there is a lot of togetherness, like they're doing everything together. They're going to agree that, you know what, you're going to do KMC for 8 hours. When I be back, I'll do KMC for 4 hours, and we shall keep on helping ourselves. Not only do they stop at KMC, but they go ahead to help each other when it comes to housework. And in families whereby a father doesn't practice KMC, there is a lot of, should I say, crashing, because the mother feels like she's left alone in the journey of prematurity.
Kubanga yamukolanga ku makya then nemukola olweggulo. Kumala ebbanga lyonna twamugya mu ddwaliro ng'akola ku makya, nze twakolanga shift. Mulaba essanyu lye nnina sinza naddi expressinga kwali we mutunuulira bwe nti ndabira ddala nga kituufu nange nsobola okukuza omuntu kubanga ninga oba nkugambe kale yakulira mu nze kyenyinza okwogerako.
For me, I believe what stops fathers from practicing KMC, it is all about the ego, whereby men think some responsibilities are for ladies and mothers, where they think practicing KMC and taking care of a newborn is specifically for mothers. I'm encouraging the fathers to always practice KMC and take care of the newborn, which is going to help them bond with their babies and increase the hours of KMC, which is going to help our babies increase weight in a short period of time.
Thank you very much, Bazilio. That was a lovely video to watch, and it's great to see what the Parents Network in Uganda is able to achieve. And it's great that all of this advocacy is actually coming from the lived experiences of not just parents, but like Dr. Rhoda said earlier, the forgotten parent. So we're going to quickly head into our next talk. Now, we've been told the numbers, we've been told, with KMC, our mortality is down 40%. We know that hypothermia reduces, we know that sepsis is also down, there's improved feeding. So we know it's good and we know that it works. And we've seen the world make the shift from spending some time in the NICU to actually having zero separation. So KMC has moved from moms just spending some time in the NICU to actually us heading towards zero separation. So now that we're talking about how time counts, quote and unquote, we need to acknowledge that this means not just starting early, but also keeping it continuous, and keeping it continuous is equally as important as starting early. And this is a great opening into our next chat. We're now going to hear from Dr. Harish Chellani, who has a 35-year background, which includes leading a neonatal unit in New Delhi. And he's also been very instrumental in policy development across India in the improvement of neonatal health. So Dr. Chellani, please take the floor.
Thank you. Thank you very much. And it's been a great opportunity to present on the KMC duration, and as you rightly said, what's the impact and what we need to do extra. So we are all aware of can I have the next slide? We are all aware of the benefits of starting Kangaroo Mother Care among stable babies, as per the Cochrane data which we had learned since the time it was published in 2016. However, initiating KMC within few hours of the birth gives an additional benefit of 25% over 40%, what you just mentioned. And since after that, the WHO revised its recommendation that KMC to be started immediately without waiting for the stability. And that because the stability takes many hours to days, and we are losing many of the babies by that time without receiving the powerful intervention of Kangaroo Mother Care. Next slide. When we talk about the duration, actually, this shows the effect of Kangaroo Mother Care versus conventional newborn care on the mortality. And in fact, this meta-analysis included the large number of studies, and the studies including the KMC starting within 24 hours, 1 to 7 days, and more than 7 days. And the pooled analysis showed that there is 32% reduction in the mortality. However, when we looked into the duration effect, the duration of more than 8 hours and more than 16 hours, they had almost the similar effect. However, we had insufficient data on the duration of less than 8 hours and its impact. When we did this sub-analysis on this difference which we are getting in the pooled analysis, they were also in all the gestational age group, below 34 weeks and above 34 weeks, at the birth weight setting, whether it is a hospital setting or it is a community setting. Next slide. When we looked at in this systematic review, the Kangaroo Mother Care, which was initiated within 24 hours versus late after 24 hours. And here we are comparing with the conventional care. Again, I'm looking at the mortality. So we had these 4 studies where we found there was a clear benefit on the mortality, which is of 22%. And there is, of course, 26% reduction in the hypothermia, and of course, 15% reduction in the sepsis. And this data also showed that there is a decrease in the length of the hospital stay. Can I have the next slide? Now, the main trial which we were doing that is the immediate Kangaroo Mother Care. And when we looked up the effect of the Kangaroo Mother Care on the mortality among the sick babies, and this was in the age group, in the weight category of 1 to 1.8 kilogram, we included both the singleton and twins, vaginal or cesarean deliveries, but of course this excluded the infants with the signs of the severe illness. And what you can clearly see, the duration of the KMC, if it moves higher, then the mortality is significantly less in that age group. Can we, next slide, yeah. So when we looked apart from the mortality, Kangaroo Mother Care also affects the other outcomes, which are growth outcomes as well as the breastfeeding rates. And when we looked up the data on these 10 studies in this systematic review, there was a clearly weight gain improvement was there for both the duration, less than 8 hours and more than 8 hours. In fact, the 6 to 8 hours had been the universally divided the duration, which is of effective duration, which we talk from the quality point of view. So in fact, when we see there was a 4.52 gram per day gain when there is a KMC with this as compared to the conventional care. And the longer duration, when we say it has the 5.04 grams per day, and similar effect was found with the weekly gain in the length as well as the head circumference from this systematic review. Next slide. Similarly, when we looked at the exclusive breastfeeding rate, we also found twofold increase in the breastfeeding rates. And this is obvious because once there is a skin to skin contact, there is an increase release of the oxytocin hormone. And this, but here what we found in these studies, meta-analysis, the short duration had a higher fold. And possibly the explanation from the authors could be possible that mothers, they get tired with the longer duration. So if there is a place for the surrogate to provide the rest to the mother, then probably these problems can be taken care of. Next slide. Now, there are some barriers to sustaining Kangaroo Mother Care of the effective duration which we talk about. And these can be, the space, because when the mothers come from the postnatal ward, it has been found that average duration for which she visits the newborn unit in the low middle income group countries, when we studied, average was 3.8 hours and the KMC duration was just 1.6 hours. So once the mother and baby are together, as it was said in the opening remarks, as a zero separation, now there will be more opportunity for the lactation, increased duration of Kangaroo Mother Care, and of course, the more important, when we looked up the mortality, then this is the same microbiota which are working, in contrast to the newborn unit where the chances of infection goes up. So another barrier is if there is no attendant actually along with the mother, or there is another challenge with the cesarean section. So these are some of the barriers, and how we overcame this. Can we have the next slide? So in this next slide, so what we found, we made a new unit, and I would suggest that in the guidelines, if it is a reorganization of the space of the mother's bed from the postnatal ward to the NICUs. So this basically, when you are keeping the mom and the baby together, along with you are providing the ancillary services of washroom and the bathing and the dining area, believe me, the duration of the KMC and the formula milk rates have come down actually in these units. Next slide. So similarly, when we see that the duration of the kangaroo mother care goes down if when there is absence of the KMC binder or the KMC garments. In fact, this provides the privacy, and also binder keeps the baby in the slightly extended position in the neck. So that's what is which is very crucial for the sick babies. And this is what we have found. If there is a KMC binder and the garment and presence is there 24/7, right from the birthing place in the MNCU, Mother Newborn Care Unit, the duration goes up actually. So this is very crucial thing when we are talking about improving the duration. Next slide. Next slide, please. So similarly, I talked about the surrogate presence. That is very crucial, and the care in the mother has to be provided by the obstetrician. So they are again very crucial, companion in the provision of this care. Next slide. Now, these are the challenges, reasons of separation. We have to keep the baby out during the phototherapy, or when we have to provide the CPAP, introduction of the CPAP or IV line. Here we would say that it should be the clustering care approach which we should use instead of doctors coming separately, nursing doing their routine separately, and keeping the baby and mom separate. So clustering approach is where all the activities are done in a single time as far as possible. And the moment you keep the baby out of the kangaroo mother position, they should be brought back immediately. Next slide. So I think the way forward is we must change our policy, we must do the training, and more important is the documentation. I'm sure somebody is also talking on the documentation, because this is another area of the research. What is the best way to do the documentation of the KMC? In the end, I would say the last slide, that there is a lack of evidence on the minimum duration of the KMC for the optimum outcome. And what we did, the trial was only on the level 2 care babies. What about the babies who are on the tertiary level of care? What about those? Can we do the same non-invasive ventilation, very sicker babies on vasopressor? That's another area. And the next is can we have the risk differentiated KMC duration on the tailored for the different clinical outcome? And of course, we have worked on the long-term outcome. The results will be available very soon. What should be the long-term outcome of the kangaroo mother care of different duration on the neurodevelopment outcome? So thank you very much. I'll stop here. I hope I have stuck to the time. Thank you very much.
Thank you, Dr. Harish, for that succinct talk. And just to highlight the whole issue of zero separation, KMC is really a package of care, as you've said. And as a lead in the IKMC, the immediate KMC is actually also the way nature intended, first and foremost, but also making sure that babies can actually be stabilized in KMC. I would even go as far as to say KMC is probably the best way to stabilize a baby, as your data has also shown. I think it would be fitting then to introduce the next speaker, which is Dr. Alex Stevenson. Alex is also, as you heard, a KMC champion and lead within Zimbabwe, and he's going to share his story with us about IKMC in his own country with data that he's also collected. So Alex, over to you.
Thank you very much, Natasha, and thanks to everyone for hosting us, and also thanks to Harish for giving my talk already. That was such an amazing talk, and then it gives me the privilege to add in a few other things, such as I think I last spoke to Harish 3 or 4 years ago when he was giving me advice about how to open an IKMC unit. And I'm very happy to report back to you, Harish, 2 or 3 years later, or 4 years even, that we've opened it. It's been a huge success, and every single thing you told me about was true. And thanks to you, we were able to do it. And I think that's the joy of community, and that's the joy of these sorts of presentations. But the question is, I mean, the data is so clear, and I don't think I've ever seen it so well presented as it was by Harish. But why is it still the exception? Why are most preterm babies in Africa, and indeed in the world, not getting immediate kangaroo mother care, etc., etc.? So I think we can flip that on its head and say, okay, what is our goal? That's the place to start. And so that's prolonged. And I think Harish raised the issue. We don't really know how long. I generally say the ideal is 25 hours in a day, and we want it to start early. So that's our goal. Where did we start? And that's a matter of semantics, because I'm pretty sure that long ago, every baby got KMC. Like, it's natural. You see a baby, you want to pick them up and put them on your chest. Somewhere in that process, Western medicine and hierarchical doctors and nurses got in the way. And then some good people in Colombia realized that actually KMC was a good thing. And then more people realized that immediate kangaroo mother care is a good thing. Nils Bergman often says that it's not that a baby's too sick for KMC, it's that they're too sick not to get KMC. And we keep seeing the data that KMC saves lives. But we're familiar with these many problems that stand in our way. The next slide, please. And so that's where we started. We have an idea of where we're going, and how do we change that trajectory? Because, as is famously said in quality improvement, that every system gets exactly the results that it was designed to obtain. And to change a trajectory takes a force, whether you're in physics or in human sciences. There is resistance to change, there's an inertia, but it's a process, and the evidence is there. Increasingly, the champions are there, and I think many of the champions are in this meeting, and we need to champion together. We need to be seen, because we can talk, but what really makes the difference is when nurses see that I'm not scared to put a small baby straight on their mother's chest and put the CPAP on. That used to shock people. Now it's common. Now nurses come from district hospitals to our big central hospital in Harare, and I'm not even on the ward, but they see nurses who are comfortable, who are willing, who are wanting to put sick babies on their mother's chest. And really, that's what makes a change. The next slide, please. This is from a few years ago within the African Neonatal Network, and we asked hospitals, what is it that is stopping you setting up an IKMC unit, an immediate kangaroo mother care unit? And generally, the light blue and the green are big problems, and the dark blue and the orange are not such big problems. And these are familiar: space, infrastructure, equipment. Those are the big ones. And the others are more amenable to change, like concerns about safety, concerns about training, concerns about protocols. Those are things that are relatively cheap and easy to change. But space, especially space, is a big problem. The next slide, please. And within that space or place, we consistently hear that we're already horrendously overcrowded in almost every African maternity hospital that I know, and then trying to put in mothers as well. It creates space issues when those mothers are there? Do they have a comfortable place to sit? Do they have a private place to sit? And, oddly enough, mothers don't just need to sit, they also need to eat and to shower and to go to the toilet and to prepare food and also to live and to be comfortable in a pleasant environment at a normal temperature. And all of these things are obstacles that are stopping us achieving proper IKMC or any KMC. And the next slide, please. And then we have changes in people. And I think Joy said a very important thing earlier on about the politics of power and control. We need to remember that families really are in control. We are there to help them. We are there to guide them, to be mentors, to reassure them. But we're not going to make this difference until we actually acknowledge that families are in control. And when we do, if you ask a mother, yes, they want to hold their babies. They want to be with their babies. All that nonsense that we hear about, oh, you can't do this and you can't do that and you can't. When you actually ask the mother, almost always, they will tell you they want to be with their baby and holding their baby. So the next slide, please. And I think this is just some data from the African Neonatal Network on a quality improvement project that we did. And I think the most interesting part of this slide is its deficiencies. This is just asking, did the baby ever get KMC during their admission? And that's better than nothing, but it's nowhere near the granular data that we need, because as you saw so well from Harish's presentation, that how soon after birth we start KMC has a big impact, but enormously important is the duration of KMC in 24 hours. And so we need to be achieving that and measuring it, which we'll hear more about later. And I think it's the last slide to say that I often say KMC is a Trojan horse. KMC is very fashionable. Ministries want to hear about it. People want to hear about it. But KMC is also a philosophy, and we can use KMC not just to change the position of the baby or the location of the mother, but we can actually use it to change the whole way that we deliver care, that needs to be hugely improved and needs to be family-centered, and KMC can be the structure and scaffolding of that. Thank you very much.
Thank you very much for that talk, Alex. I think that what really caught my attention from what you've talked about is that change really does require a force. And I think one of the first steps in being that force is us gathering, first of all, in such a manner and having great minds such as yours and all the other speakers from today actually remind us that we are the ones that need to be this force. And the mindset change that you spoke about as well, I think is really the key. And if we have peer learning such as this on a platform such as this, I'm coming from Zambia and I can see Zimbabwe has managed to do that. It makes it easier for me to relate to. And I think all the listeners that are with us on the webinar today would do well to take a leaf from that. What we've seen is an overarching and resonating theme through all the talks so far, from Alex's talk to Bazilio's talk, has been about the importance of a companion. And when we talk about time counts, as we discuss KMC, we're thinking about the minutes or the hours, but behind all that time, there are people that actually have to carry out this activity of kangaroo care, whether it's the mother, the father, whichever family member. So companions, and these can be partners, mothers, fathers, grandmothers, or even trained peer supporters. These are often what makes continuous skin to skin possible for the moms. They can offer relief when she needs to rest. They can advocate when other routines are getting in the way, and they can keep KMC going even when the staff are quite stretched thin in our neonatal unit. So today we're going to hear from Helen Brotherton, who's a neonatal consultant, and her work spans work in the Gambia and other NHS research, and all of these are driving the optimization of skin-to-skin duration for our babies. Thank you.
Good afternoon, everyone. I'm Dr. Helen Brotherton, a consultant neonatologist in Scotland and Kangaroo Mother Care researcher in the Gambia and the UK. Thank you so much for the invitation to speak at the Newborn Toolkit KMC webinar today. I'm sorry that I can't deliver this talk live, but I'm delighted to talk to you about companions to enable KMC What Works. So as I think we all know, family support is really a core part of Kangaroo Mother Care for both stable and unstable newborns. The WHO Clinical Guidance 2025 for Kangaroo Mother Care recommends that the mother is the primary KMC provider, but also that a family member or a companion supports the mother in providing skin-to-skin. Companions, as well as delivering direct skin-to-skin care, they're also incredibly important to help mothers with practical chores that they may have within the hospital or the home environment, and also to provide emotional support to mothers. In terms of terminology, various names have been used in the past, such as substitute, surrogate, helpers, but in the WHO 2025 guidance, they suggest using companion as the preferred term, really to emphasise the supportive, family-centred approach rather than a mere clinical replacement for the mother. So if we want to start Kangaroo Mother Care as soon as possible after birth, in line with WHO 2022 guidelines, then it's critically important that companions are involved. Our eKMC trial in Gambia a few years ago randomised unstable neonates to either Kangaroo Mother Care within the first 24 hours or once stability was reached, which was around 4 days. And it was very, very difficult for us to conduct that trial without companions, as approximately 50% of mothers were unavailable, typically due to being unwell, admitted to another health facility, or post C-section within the first 24 hours of admission. And it was really the aunties and the grandmothers who were providing that initiation of skin-to-skin contact. And then once the mothers recovered and were able to come to the neonatal unit, they could then take over the Kangaroo Mother Care. Another group that we identified as being really important for KMC companions was twins. On a sensitivity analysis of our KMC duration data, we identified that twins receive less skin-to-skin duration every day compared to singletons. And from our practical experience, this was really due to difficulties with unstable neonates with IV fluids, oxygen tubing, pulse oximeters. So providing skin-to-skin to both twins who were unstable from one KMC provider was highly challenging, and that's where the companions came in incredibly useful. And that also fit with maternal carer preference to provide one twin with KMC until they became more stable. The Umwana trial in Uganda published this very interesting analysis led by Dr. Tumakunde, identifying that if there was a KMC companion present, the daily duration of skin-to-skin provided was 1.9 to 2 hours greater compared to if there was no KMC companion present, really identifying how important it is to involve companions to reach the WHO recommendation of more than 8 hours per day of skin-to-skin. And in the Umwana trial, it was really aunties, grandmothers that were providing that companion KMC, but also fathers and some siblings. Really important to understand the views of companions towards providing KMC. And this was a qualitative study we undertook in the Gambia during the EKMC trial, led by Maura Daly. And we interviewed aunties, grandmothers, great-grandmothers, who overwhelmingly expressed a collective responsibility for newborn care and for supporting the mother in newborn care, and that this extended to Kangaroo Mother Care as well. So there was willingness to support mothers both in doing skin to skin, but also emotional support and practical support for mothers. So a quote here: myself, my husband, my co-wife and my co-wife's eldest son, we all join hands to care for our children. We are all united. And we identified some important enablers, such as this feeling of duty, some flexibility within the extended family in providing step-in roles to support mothers, and that this role, this additional role of supporting KMC, really reinforced positive family relationships. But the barriers that we identified were that older generations of relatives may be less accepting, and this was in the context of KMC just being introduced into the Gambia at this time. And this may represent an additional obligation and workload for companions. And it was seen very much by our participants as a female role rather than a male role to support women in this way. So what did we identify during the EKMC trial that really helped companions to support KMC? Well, at the individual level, working with the healthcare workers so that they could support companions during the first few days was really critical. And at first there was some reluctance about allowing additional people onto an already busy neonatal and KMC unit. Early sensitization, education of families in the antenatal clinics and immediately on admission to the neonatal unit was also very valuable, especially for twins, and preempting that there may be some patients who need an additional family member there from the outset, and having those conversations early during the antenatal period was very helpful. We also had education checklists, which we used to go through about KMC with carers, with mothers and companions. And at systems level, we had to do a lot of work around the security policy and the guidelines for who was allowed on the neonatal unit, how many people, and have this shift in culture towards each mother on the KMC unit being allowed one helper. We also had to do work around infection control, so involving the IPC teams, making sure they were on board with having additional people on the unit, and renovating the wash, the toilet, the shower facilities for the companions as well as the mothers. Also thinking about sleeping arrangements, free food provision, and practical space for additional chairs and beds. So to summarise, KMC companions are absolutely central to KMC provision and essential for meeting WHO guidelines for duration and for starting as soon as possible. Having a companion there will prolong the skin-to-skin duration you can provide, and it's not an inferior alternative to mothers. There are research gaps, particularly around strategies to support and enable companions, which are currently lacking. And I would challenge you to think about what steps you can take on your neonatal unit to encourage and support KMC companions and promote truly family-centred care. Thank you very much for listening. I can be contacted on these email addresses if you have any questions. I'd just like to thank the EKMC team and also the Onwana team for sharing the data and the work that they've done in this area. And lastly, thank you to the companions, without which the EKMC trial would not have been possible. Thank you very much.
So we're going to thank Helen in her absence, but Helen, that was an excellent talk on companions and how important it is if the mother's not available to provide companions in care. So I'm going to move on quite swiftly to our last speaker, but not the least. It's Julius Thomas. He's our Nest 360 Alliance data analyst based in Kenya. Julius, I'm going to give you the floor and you've got enough time to finish your talk, so please go ahead.
Thank you, Natasha. So building on insightful talks that we just had on KMC practices, we strongly believe that KMC is one of the most cost-effective interventions with lots of benefits. But the critical question is, how do we measure KMC? And most importantly, how do we ensure that the data that we collect from KMC is used to drive change? Next slide. To briefly ground this discussion, Next 360 is an alliance of 23 organizations that are working to end preventable newborn deaths across sub-Saharan Africa. And within this Next 360 network, data is no longer just being used, not being collected, but it's used to improve both the coverage and the quality of KMC. Next slide. So currently, the coverage indicator is the only WHO recommended indicator that is measured for KMC. There is no guidelines out there for quality indicator. So that's why we're gonna look specifically at KMC coverage for now and then see what's there to be done. So looking specifically at KMC coverage, it's crystal clear that over the years, we've witnessed improvement in KMC coverage across the entire networks. Next slide. However, despite the improvement in KMC coverage, KMC care cascades reveal quality gaps. So let's find out how. So for this specific KMC care cascade, you've realized that only 5% of eligible neonates received continuous KMC from the same day through to discharge. So this highlights a major gap in the documentation, early initiation, and continuity of care. Next slide. For this KMC and nutrition cascade, it's about 19% of eligible neonates received both KMC and same-day breastfeeding through to discharge. And this demonstrates that there exists still missed opportunity in early initiation and continuity of breastfeeding. Next slide. And lastly, when we examine the KMC and CPAP care cascade, about 5% of eligible neonates for both KMC and CPAP received the CPAP. So this exposes that we still have some gaps in trying to integrate care to the neonates. Next slide. So how does the network been ensuring that the KMC data that we collect, we make it owned by the facility and used at facility level to drive change? So this is achieved through facility-led keyword interventions or projects, and I'll illustrate this using the example of Facility 404. So at facility level, we are able to see that the team first start by reviewing the data that they have. And in this case, over the last year, they realized that the KMC has been constant at 50% on average. Then they go ahead and ask, why is this happening? So maybe they have a target of now improving the KMC coverage from 50% to 70%. So what they do is that they conduct root cause analysis to find out the reasons for this and then implement change ideas in order to improve the coverage from 50% to 70%, which they finally achieve successfully. Next slide. So the network also captures valuable data in time to KMC initiation. So this graph presents time to KMC initiation, which is calculated based on date of birth and the date KMC was initiated. And we have categorized this into 4 main categories. So we have same day, early KMC, delayed, and finally the late KMC initiation. So over the time, we are beginning to observe encouraging increases in early KMC across countries. And so is also the improvement on documentation, because there have been quite significant reduction in the missing data across all the countries. Next slide. We are also able to understand how the median time to KMC initiation changes with time across facilities within the network. For example, within the graph, overall for the past 2 years, if we take a look, the median time to KMC initiation has reduced across countries at different rates. So this is also helpful because it's helped to see where the countries are and where they are going. Next slide, please. So the model used within the network currently is to learn from KY project experiences and try to scale this over other facilities. So to better understand how these models works in practice, let's switch gears now to a cross-country KMC learning visit that was conducted last year in Ethiopia and see what the data is currently trying to tell us. So please, may we move to the next slide. So here, a set of 5 facilities were benchmarked that have been actively implementing KMC, and let's see what their data is trying to tell us. So from this graph, the visit that was conducted last year led to a meaningful reduction in the time to KMC initiation in facility 4.1 and 4.2, as backed by the performance in the reduction in the median time to KMC initiation, while if we have a look at facility 102, it sustained, while facility 3 or 4 regressed. So it's very important to learn from such kind of experiences to see what's working in other facilities and what's not working so that we can borrow or scale out what's working in order to increase the KMC coverage as well as the early initiation. Next slide. So let's pause and ask this question here. How can we ensure effective coverage across different sites or across different countries? So if we take a look at this graph, yes, we are reaching the babies as backed by the strong KMC coverage both before and after the Ethiopian visit. However, the caveat here is, are we really reaching the babies early enough? Same-day KMC remains relatively low both before and after the visit. It's therefore important for this specific facility to shift focus from just the coverage and ensure that we bridge this gap and ensure we have timeliness in coverage. Next slide. So finally, what does this mean for all of us? Do we have the right data? So within the network, yes, we have lots of data that can help us improve KMC coverage. So are we really driving change? Yes, but we can do more. Therefore, measuring KMC duration in days is no longer fair enough. It's time to measure KMC in hours so that we can have that timely and improvement in quality of care. I think I'll pause here and thank you very much for listening.
Thank you so very much for that talk, Julius. Great take-home points for all of us to be able to apply in our different areas of work. Only because we are so pressed for time, we'll go on to just giving a few take-home points. Thank you to everyone who has been in attendance. And our challenge to you today is give yourself something that you can do. What's your take-home between now and next week? Pick one thing that you can do. For example, you can set a visible target. Put a poster in your unit at the nurse's station that says we have an 18-hour KMC goal, for example. And at handover, make sure that you and your colleagues are able to count the number of hours that the baby spent. Your shift handover should also include, how many hours the baby spent in KMC, and then track and see if that changes over a week. And then, introduce the practice of having companions. Ask the staff or parents, when does KMC usually stop? Is it during bathing? Is that the time when you should include the help of a companion? And just make small changes, which in the long term can have big impact. A huge thank you to everyone for joining us today. A huge thank you to all the speakers. And We also thank all our funders, funders of the Nest 360 Alliance, like the Gates Foundation, Elma Foundation, the funders of the Newborn Toolkit in French, the Newborn Toolkit Expert Advisory Team, and then the Newborn Toolkit team that is based at the London School of Health and Tropical Medicine. Thank you everyone for joining us, and we invite you to attend our next webinar. I think scan the QR code so that you can stay in the loop with all things Newborn Toolkit. And thanks once again to all our speakers, my co-chair, Dr. Rhoda, and all the people that have been in attendance. Thank you very much, everyone.